While preparing for this, my thoughts really went all over the map. First, I thought it was easy. It was easy to list everything we did not know, but then when I started doing it, I realized that we actually do know a lot of things about a lot of things, and that the problem is probably more getting it done. This has been said before, but it's often presented as a KT problem. I think we do have a KT problem, and I'll come back to this a bit later on. But I think that more fundamentally, we lack knowledge about, so we need more research about how to actually get things done. So I regroup my thoughts around what is it exactly that we want to get done? What's the point of, too short to advance, what's the point of health services and policy research today? So the point, I think, is quality. I'm not the first to say that, obviously. This was the message of the FIKE report in 2001 Saskatchewan, several reports by the Institute of Medicine in the States, Michael Reckless' book on prescription for excellence also had the same message. So what is known and what is not known about quality? I think to some extent, we know what quality is. Not because there has been some great research on what quality is, but because it's a very intuitive concept. The American philosopher Robert Pirzig said that it's a fundamental force of the universe. It's the reconciliation of subject and object. So in our case, the reconciliation of patient and care. So we may not know how to define it, or we may not agree on how to measure it, but we would recognize it simultaneously if we saw it, and we don't see it. So what do we know about how to do it in healthcare? We know it results from multi-level phenomena, from micro-system level characteristics, attributes, and processes, from organizational level attributes, practice, and processes, and from micro-level or clinical level practices and processes. We know quite a bit about system-level attributes and processes that are required. So strengthening of primary care, universal coverage, integration, performance management, focus on prevention, those type of things we already know quite a bit about. At the clinical level, we also know quite a lot. There's been a lot of effort in trying to get providers, individual providers, to adopt evidence-based practices. But what I'm most interested in, and I think we know less about and need more research, is about the meso, or organizational level, and the link between the organizational and the micro-clinical level. What do we know about the organizational level? So I just summarized there very briefly some of the work that has been done, and that was very well summarized by Ross Baker on his book on quality by design. So we know that strategy will influence quality. We need a focus on quality to get quality, structure, culture, systems, so quality improvement systems and information systems, enlightened leadership, and professional engagement. That's clear enough. But what we need a lot of more research on is how do we get organization to adopt and implement these key quality practices and processes. So I'd like to suggest in my presentation a series of hypotheses or research questions to advance our understanding of this broad problem. I think we have to study both organizational failures and governance and management failures. The first organizational failure, I think, is one of organizational model or business model. We need more knowledge about how best to organize services delivery to deliver high quality. One of the most stimulating concepts to appear in the last decade, I think, is the concept of disruptive innovation, put forward by Clayton Christensen from Harvard. In his 2009 book, where he analyzed the potential role of disruptive innovations in healthcare, he convincingly argued that the delivery of care has been frozen in two business models, the general hospital and the physician practice, both of which we developed more than a century ago. They were appropriate then, given the nature of understanding of disease and of care at the time. Care was mostly based on intuitive medicine, so where professionals solve medical problems through pattern recognition and intuitive experimentation. But according to Jerome Groupman, at most 15 to 20% of patients nowadays require intuitive medicine. Management of most patients should rather rest on empirical or evidence-based medicine, where data can be used to estimate what might be effective on the average, or hopefully more and more on precision medicine, where with precise diagnosis, a therapy can be developed precisely for an individual patient. The best business model to deliver intuitive medicine was, and probably remains, the solution shop, which general hospitals are. But it is a very inefficient model, by which I mean low quality and high cost, for delivering evidence-based care and precision medicine. We could discuss this at length, obviously, but the point today is that we need to experiment and evaluate a wide range of business models to deliver care to various segments of patient population with diverse needs, depending on the nature and degree of precision by which their disease is understood. Despite all the current rage for integration, we actually need a disintegration of organizational models in an integrated value system. The second organizational failure I wish to discuss is the failure of KT, particularly in organizations. The basic KT model is one where we have to move, or we're trying to move, from ignorance to knowing to doing. KT is quite good at moving from ignorance to knowing, but the gap between knowing and doing remains quite big. But to get organization to use knowledge is even more complicated, primarily because the knowledge that we're usually talking about is individual knowledge, not organizational knowledge. So not only do we have to move from individual ignorance to individual knowing to individual doing, but we have to move then somehow to organizational knowing and organizational doing. And that we know approximately nothing about. The link between individual knowledge and organizational knowledge is surprisingly unclear. So my second question, how to convert individual knowledge about quality into organizational practices and processes. I also think that our inability to adopt and implement key organizational quality practices, processes, rest on governance and management failures. The first governance and management failures is certainly a failure of current incentive system. First, the system is full of perverse incentives that we seem incapable of getting rid of. As Stephen Lewis wrote, it is clearly more lucrative, particularly in primary care, to practice bad medicine than good one. The system also sends multiple mixed signals about what it is that we're trying to get done. But more importantly for research, we don't know what makes people tick. By people, I mean professionals and managers, if managers are people. What motivates professionals and managers? Our consideration and knowledge about incentive is limited, and it is restricted to financial ones. Even for these, we need more research on what works for who, under what circumstances, with what intended and unintended consequences. But more significantly, we do not know about other aspects of performance motivation that could be based on more true intrinsic motivation. We need to further experiment with financial incentives, clearly, but we also need to better understand about non-financial intrinsic motivation of professionals and managers. Finally, the last governance and management failure I want to discuss is a failure of adaptation of management practices to the particular feature of organization and system where most care is delivered, that is, complex adaptive system whose production is based on professional work. These are highly fragmented, highly decentralized. Some part of it, as we just discussed, have fuzzy production processes with weak standardization mechanisms. Other parts may be highly standardized. Boundaries are very permeable. Production relies on widespread interaction among relatively small production nodes, highly interconnected within the organization and with the outside. In such context, we need further knowledge on three particular issues. Clinical governance, by which I mean the management of microsystems of care through organizational processes. The core but little understood relationship between organizational level practices and processes and micro level delivery of care. Second, the management of professional engagement. We know that quality and involvement in complex professional organizations rest on professional engagement. I really believe that one of the major changes we have seen over the last decade or so, leading to some deterioration in quality, is a disengagement of professionals. We need to better understand the factors of professional engagement. Finally, we need to advance our knowledge about the management of paradoxical performance. This is obviously my day job, and I'm biased toward this one, but the performance of complex systems is paradoxical. It's inherently, by that I mean it's inevitably multidimensional. The different dimensions require apparently contradictory determinants, and the management of performance requires the management of trade-offs among the dimensions. Performance management in such context must resist simplification and acknowledge complexity and paradoxality. We have to learn more about how to manage paradoxical performance. We need further understanding. To do so, we need further understanding of cognitive processes. How do individuals process multidimensional paradoxical data? We need to develop and experiment tools for the configurational analysis of paradoxical performance. And we need to develop and experiment with organizational processes. What kind of deliberative processes are most appropriate to collectively construct judgment on paradoxical performance? Thank you.